Hello, everyone, and welcome to today's program, How Avera Health is Connecting Caregivers and Improving Patient Outcomes, presented by Volt and hosted by PSQH. My name is Michelle Clark, and I'll be your host for today's webinar. Our program will be 60 minutes in length. The first portion of the program is presentation, followed by a question and answer session. Today's program is being recorded. Before we get started, I'd like to take a moment to review the web conference platform. First, to ensure that you can see all of the content for the event, please maximize your event window. Second, be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Third, at the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which is a question mark icon and covers common technical issues. We're very pleased to offer you this free educational opportunity by Volt, and now I would like to introduce today's speakers. First is Candice Friestad, Director of Clinical Informatics at Avera Health. Next is Cheryl McKay, Chief Nursing Officer at Volt. And finally is Chris Sullivan, Global Healthcare Practice Lead at Zebra Technologies. And finally, before we get started, note that an on-demand version of this program will be available approximately one day after the completion of the event and can be accessed using the same login link that you used for the live program. Also, a copy of today's presentation is available in the Resource List widget, which is located in the lower left area of your screen. And with that, I would now like to pass the program over to our speakers.
Thank you so much, Michelle. Appreciate that. So this is Candice Friestad, and I'll be talking about these three learning objectives, although we will go into deeper dive on several of them. The first is the ability to smooth the discharge process and to speed patient throughput. That was one objective that we had. The second was to streamline the medication order and administration process for optimal patient care. And the third is to optimize our alarm management to ensure patient safety. So those are our three learning objectives for this program, but it was also our objectives for the actual rollout that we did. A little bit about Avera Health. Avera Health is really in the upper Midwestern portion of the United States. We encompass 8 states. In that platform, we have 33 hospitals, 208 clinics, 40 long-term care facilities that equate with, from a hospital perspective, to approximately 45,000 annual discharges. We do have home health, and we have a very robust e-care and e-telemedicine platform. We are self-insured, so we have 1 million covered users within that insurance platform, and that encompasses about $2.8 billion in revenue. In that platform, we have over 60 medical specialties. We have 876 employed providers. However, throughout that platform, we also involve many independent providers as well. Our annual clinic visits last fiscal year, which was July to July of 2017, was 2.7 million visits. We have about 16,000 plus employees for Avera, and then we also have about 2,700 volunteers that assist us with many a variety of different opportunities within the different care settings. So one of the things that we try to tackle from an Avera Health perspective is to cover the full continuum of care. And I won't go into great detail with this, but one of the things that we've seen a migration from the actual tertiary hospital care more to what care can be delivered at home, what kind of long-term care and assisted care elements are available. We all know that the health insurance platform right now is certainly a very high point of discussion, both at the government level as well as over coffee, for that matter. What's going to happen with health insurance and payment for the care that is required. We also have a sports medicine and a very robust orthopedic medicine platform with Avera Health, and we want to make sure that we keep the healthy part of that and not necessarily the care or the surgery part of that at the forefront. We wanted to operationalize our community and rural health hospitals within the Avera platform because, as I stated earlier, it's in the upper Midwest, and so that includes South Dakota, North Dakota, Minnesota, Iowa, Nebraska. And as we cover those states, we have several states that have not only rural counties, but counties that are referred to as frontier counties. And a frontier county, in order to equate to that, means you have less than 6 people per square mile in that county. And we have several of those that really need some form of health care, and we wanted to look at the technology that we could operationalize that in the best fashion. And that also from a home care perspective comes into play. And in addition to that, we also have a very robust hospice platform that we utilize, and then at the very top of it is occupational health and our telemedicine platform that can help us with that full continuum of care. So the vision that we came up with was really impetuous by the bedside caregiver, and that not necessarily just nursing, but also a variety of different ancillary departments who felt like at some point in time, they had a variety of different communication methods, a pager, a mobile phone, they had a landline phone, a computer that they would use, and at some point a variety of individuals came through and said, is there some way that we can integrate technology so that we don't have these multiple devices, but we really want to make sure that we have a patient experience, that there's satisfaction gained in that. So after multiple conversations with our bedside staff, our providers, our ancillary staff, we came to this vision that drove this project, and that was to integrate technology into the patient experience such that patient satisfaction, patient safety, staff satisfaction, and operational efficiency are achieved. And then we went one step further, and we said, how can we have voice, text, and alerts and alarms on one device? And that is really the point that we started at, and how do we get there? So a little bit about Avera has the largest facility in the Avera platform is Avera McKinnon Hospital, and we started our journey here, and that is located in Sioux Falls, South Dakota. We are licensed at 545 beds. We cover most specialties, meaning behavioral health, cardiology, pulmonology. We have both bone marrow and solid organ transplant. And then, of course, med-surg, pediatric. We are a level 3 NICU, and we are a level 2 trauma center. The reason we're a level 2 trauma center is just because we don't cover 1 million in our larger footprint. So if we had 1 million, we have all the items to make it to a level 1, but because we don't have 1 million people in our footprint, we are considered a level 2 trauma center. The interesting piece of that is some of both our fixed wing and our rotor wing flights will go miles just because of the rural footprint that we see. From a perspective of we are healthcare's most wired. We've been on that list for 14 times, and also the most wireless list. When that came out, we were also part of that. We are currently working on our 5th magnet redesignation, and for those of you that have done the magnet journey, you understand that that is a high esteemed level that we're very proud of, and also with Magnet's perspective, they indicate to us that every time you get that designation, they raise the bar. And so that means it's every 4 years that you're designated, and so we've been in that role for 20 years, and indeed they have continued to raise the bar for us on that. HIMSS Analytics, we are stage 7. We achieved stage 7 from an IDN or interdelivery network perspective, and that we attained that stage 7 in 2015. There's a variety of other items that we have for certification, stroke certification. We're CAP ISO certified on our lab side, but I wanted to designate these particular items or articulate these so that you can see what level we're at from a technology perspective. So the big question was, how do we integrate a healthcare platform for communication among providers and interdisciplinary teams? We did not want to do this in a silo format. We wouldn't look at it and say, well, this unit has this communication and this unit has this, or even this discipline has this communication and this other discipline has this. An example would be as we entered into this one facility, one unit that we had, which was a 52-bed medical unit, had used Cisco mobile phones, and then another unit just used pagers. And one of those things was, well, how do I get a hold of this person when I don't know this person has the mobile phone and this person has the pager? So we looked at how can we put everybody on the same platform rather than having to make it either unit or discipline unique. So what we ended up doing is putting a look out at what we're already doing. And I'm going to just back up for just a second on that. What we realized at this point as well is that everybody, for the most part, had a smartphone in their hand. And that meant that they were using that from a communication perspective already. How could we operationalize that so that we made sure we used something that was already comfortable with some people? Now, given the size of our employee base, we did, of course, have the occasional people that still utilized flip phones, and so we did have to have those conversations. But for the most part, because the functionality of a smartphone is already pretty much embedded in the culture and the social network of our employees, we really wanted to try to leverage that as much as we could. So what we ended up doing is taking a look at our Avera Medical Group and our Avera Employed Group to try to figure out how are we going to best operationalize this. So we landed really on a smartphone solution so that we could communicate both with secure text and secure voice for the various different disciplines, and then how can we also utilize that to integrate alarms. So I will currently, our current setup is we have 300 providers and 30 provider groups that are on the smartphone app, and these providers cover a 5-state region. We started our journey in October of 2015 where we implemented one pilot unit, and our unit was that 52-bed unit I had discussed earlier, and we integrated the smartphones and the alarm integration into that unit first. About 3 weeks into that journey, our staff came up to us and said, you're not actually going to take this away from us because we said it was a pilot. Are we going to really remove these very efficient, very patient and staff satisfied method of communication? And we decided at that point, okay, we have to operationalize this and really see it hit all of our footprint. And so from October 15 until today, we have really embedded that into our communication methodology. So how that works then is once we have this in the hands of providers, of nurses, of case managers, social workers, EVS staff, security, and then those providers that are out and about, they come up with use case scenarios that allow us to say, hey, could we use this smartphone to be able to do this? And the picture that you see on the screen is one example of our athletic trainers saw that our providers, our orthopedic providers, and we also have an orthopedic traumatologist group, had these smartphones in their hands, and they said, well, wait a minute, can we utilize that as well? So we basically put a smartphone in the hand of our 14 athletic trainers, and then as is probably the case in the entire country, but definitely here, Friday night and sometimes Tuesday night is football night for many small communities in this area. We deploy our 14 athletic trainers to a variety of different football games, and with that smartphone secure app in their hand, they're able to communicate directly with the traumatologists and the orthopedic surgeons in the event that there's something that they need assistance with. And so that was a use case scenario suggested by both the providers and the trainers that really from a leadership perspective as deploying this solution, it really hadn't occurred until that happened. We had the same situation happen is people think innovatively when they have the correct tools in their hands. The other thing that we do is we have EDs remotely also positioned, and the same type of thing there with any specialty consults. And here's sometimes where they use that secure, the ability to take secure pictures on their phone so that they can communicate, and a picture is 1,000 words, and sometimes that communication of either a specific rhythm or a specific non-diagnostic, looking at a non-diagnostic x-ray or dermatology with skin and wound has been very helpful after our deployment of the smartphone application. So just a little bit more on provider communication. What we really looked at also is being able to securely have that conversation between a phone and between a PC as well. So our deployment for this has hospital-supplied smartphones, and we use Droid MC40 phones for those for our hospital-supplied group, and that phone stays with the caregiver and then is handed off to the next caregiver, except all of those phone numbers are user-based. So that definitely allows us to have a directory structure so that you know you're calling person to person. We also have pictures on that, which I'll get into in a few minutes. But that is one part of the application. The other part is actually the cellular phone or on a personal or a BYOD device. So same basic app versus the smartphone app that the staff have in the facility. One is wireless, one is either wireless or cellular. Then we also have the ability to have that messenger component in the PC itself, and this is one that we use a great deal in our e-telemedicine area. So our telemedicine footprint covers not only our e-transfer center so that we can have those communications, secure communications about patients that are coming in that are going to be transferred to one of our 30-plus hospitals and at the hub, at our e-hub. But in addition to that, we also have e-long-term care and e-hospitalist services. So the e-long-term care covers those 40 long-term care facilities. We have the ability to have that PC secure communication between the e-hub as well as to the caregivers out in the community, really using a PC for that secure communication in addition to the other methods of communication on the smartphones. So one of that is another piece of use case scenario that once it was in the hands of those caregivers, it just allowed them to have that direct one-on-one communication that probably was handled in a series of handoffs where I need to get this person or a page of this individual. They call a landline. They have to get a hold of somebody else who's maybe busy doing something else. And so that really made that one-on-one direct line of communication eliminate both the handoffs and the time that it takes to be able to get that communication to happen. We also use that same functionality in our clinics. We have individuals in our clinics called PSRs that have that functionality on the screen, and that allows them to securely communicate with the providers that are out in the community or in outreach. To be perfectly transparent, we are certainly aware that some of that non-secure communication was happening with their own personal cell phones. This way, we have truly indicated, and our senior C-suite leadership has been very direct in this. If you're going to use the system, you must use the secure technology, the secure availability for the texting, not your own personal text-based system on your smartphone. And so we've been very specific with that directive so that we can keep our communications secure. Part of our future functionality then for that is pager replacement, so that we do get rid of our pagers. An interesting sidebar to that is we just opened up a standalone emergency room in our community of about 180,000 here in Sioux Falls, South Dakota. And when we opened up that individual entity, the two-way pager system would not cover because they had not put up another tower and really had no intention of doing that. So we were able to put our smartphone communication piece in that and really eliminate pagers from that perspective. We're also looking for call scheduling to be able to use it from an on-call perspective. And then we already talked about secure patient texting, and then we'll get to the alerts in a little bit. And then the other piece we kind of use it for is our rounding list for our hospitalists, because our hospitalists are color-coded, and we have the ability within the app from the directory perspective to look at that coding piece. I'll talk about that in a minute. So there are certain barriers to provider adoption. The one key piece that we had is a very strong C-suite both authority, accountability, and directive that this is the functionality you're going to use because secure is very important. We also operationalize provider champions not only in one site with our chief medical information officers, but also an individual champion in every one of the facilities that are live with this functionality. And then we trained all to use, not just bedside nurses, but we trained really an ancillary perspective of that so that the right people were communicating with each other. You have the ability to do quick and group messaging. We set our tones on the text-based tones to be able to specific either an emergency tone or not. And then we have the ability to set up favorites for units, users, and teams. When you're across a platform of multiple facilities, it's very nice to be able to say, I work here, and these are my favorite users and my favorite teams. It makes sort of one-stop shopping for when you need to text those individuals. Our push notifications work with reminder tones, and that really is an ideal situation and almost necessary to be able to do the pager replacement. Then we also have the ability to integrate our rooms into that. In other words, I can look as a physician to see what rooms a particular group of people have, and then I can go directly to that individual. Again, more on that in a minute. We did have to definitely optimize our Wi-Fi. In any particular facility that goes live with the system, we look strongly at their current Wi-Fi use and whether or not APs need to be added or we need to look at specific bandwidth. Then from a critical notifications perspective, we utilize this from our EHR, and then we were also able to use this. We recently had a transcription downtime that really affected many users across the globe, and we were able to indicate specific notifications on that downtime and workarounds for the downtime by utilizing the system to be able to give those messages automatically to the appropriate providers. It allows us to do consult and referral management. We had an example of shortly after our go live in one facility where a physician was monitoring a new patient that really, from an oncology perspective, needed to see a specific surgeon and oncologist. He quickly looked at his directory, noticed this person was online, and they immediately had a chat. That person was in surgery the following day, and he indicated to me anecdotally that that would not have happened had he not had the smartphone capability to do that. So what we did learn, however, is there's some do's and don'ts. So if you think about using a text-based or your cell phone, and if it, not so much you, but if you have millennials or as I have children in their late teens, early 20s, they've had this technology forever, and there are certain specific individual things like IDKs, LOLs, other things that happen in text messages that maybe just don't make the most sense when you're talking professionally and for provider and other ancillary communication. So based on a lot of feedback from our physicians and other providers, we did come up with the top 10 list of Avera Volt do's and don'ts. And the first one was do include patient information such as name, room, number, diagnosis, and procedures when you're using the text-based function of this. In other words, if you just say a text gain indicating, hey, do you think this person or do you think she will be discharged, chances are that provider sees many patients and you won't know exactly who they're talking about. So again, be cognizant of the fact that the individual you're texting may not know exactly what you're texting about. Do use the read receipt to see if the provider has received the message. If not, you have the ability to resend that, but give them a little bit of time to look to see, yes, they've read the message. When you answer the phone, if you answer a landline, most caregivers would answer their name, their credential, and what in unit or what area they're working on. On cell phones, typically, as social norms have changed, there is that possibility of saying hello or sup. And so we did indicate that you can't treat this cell phone as just something you use at home. You really do need to look at it from a professional perspective. And so, again, name, credentials, and where are you from, even if it's not just a landline, but also the phone in your hand. You do have the option to use an urgent or a high priority tone to indicate if it's urgent, and if so, that's what that text is for, or again, certainly calling is capable of handling that as well from a high priority. We do suggest strongly that the room number assignments are in. We started out with that particular functionality about 2 months ago or now. It is such a time saver that really we don't even have to remind that anymore because of the way once that person is identified as a room number, it really does help with the efficiencies of not really having to explain what conversation you're having. And then, of course, there's the don'ts. The don'ts are if that individual is offline, please do not text them information because they're offline, and truly there is someone else either on call that you need to have that conversation with. If you have a provider that has a status of busy, which you have that capability on the phone, then do not text them information either because they're busy. They could be in surgery, they could be in clinic, they could be totally on outreach, so please do not do that. Another don't was do not respond K or thanks or thank you. And the main reason for that is we had a provider that went on a no thank you. He individually went to various different units and said, you do not have to tell me thank you because it's just another text, and it created text fatigue. And so he went on a no thank you campaign throughout Avera to say, I appreciate you, but you don't have to tell me thank you because it's another text that I need to pay attention to. And then do not text issues of convenience. In other words, if you know they're going to round already today, and really 2 and 1 go together, then don't text them that information. If they're going to round, have a conversation with them, and then certainly after rounds it's possible, but allow your providers to do the work that they were going to do to begin with. And so that was something that we shared with everybody recently. Just as we got comfortable with the system, we did have to look at what the do's and don'ts were. So how we accommodated all those directory items that I talked about. We currently have 3 facilities live. Our plan is to go live with all of our 33 facilities. But to start out with, we're live at our largest facility, McKinnon's in the upper right. And then we have a regional facility, Avera Sacred Heart is 90 miles south in Yankton, South Dakota. And then we have a critical access facility. We have quite a few critical access facilities, and we went to Dells Area Hospital with our implementation to make sure that we could do this in a clinic, long-term care, small critical access facility, and what would the platform for that look like. And so we did implement there to begin with, and then we have plans to go to our next regional facility here in the next couple of months. One of the things that we got very detailed with is we knew that we were going to do this on a interdelivery network perspective, and so we had to look at what's a home, what's a building, what's a department, what are teams, what are roles, and then how do you operationalize rooms with that, knowing that you can't have a room in room 1 in 33 different hospitals and still call it room 1. So we spent a lot of time with our bedside user staff as well as our providers. How does it make the most sense to make sure that you are who you are, that your facility is in your facility, and that the teams like a hospital's team, the purple team, the gray team, the teal team, that those people are dedicated to the right patients and the right ancillary caregivers that follow that service along. There's also the ability to have favorites, and so again, we tell people in education favorites is your friend, and so if you always know that you're working on this particular area and you have a dedicated pharmacist or a dedicated food ambassador, those are our tray passers or our nutritionists, use those as favorites so that you can get the quickest one-touch shopping with your directory structure. So the directory also is very robust in allowing for the searching of both names. If I know the name of the person that I want to talk to, if I know their role, are they a resource or a charge nurse, are they a patient care tech, or if I know what rooms they're covering. So that really gives me the option of I can search in a variety of different elements of care so that I can get the right individuals. For example, if I choose a specific room, I will get who the pharmacist is that's covering, who the hospitalist is that's covering, who the nurse, the patient care tech, the respiratory therapist, the case manager, and the social worker. Who are all those people that are covering that one individual? That is a huge time saver from an efficiency perspective. And this just gives you an example of the role. So if you are a nurse, but you're assuming the charge nurse role that day, then you can give yourself not only the entity of you're a person, you're an RN, but you may also be a charge nurse. And so in that event, you are covering maybe 1 or 2 or 3 roles during the course of that particular shift that you're working. It's an ideal way of looking from a leadership perspective. We can put charge or resource into that search field and come up with all of the individuals if for whatever reason I need to speak to all of them at once, and then I can group text all of them at once. Same way with respiratory therapy or ICU. So if you think about the different nomenclatures within a care facility, you have that capability of not only doing the search, but also finding the right individual or messaging them out together if need be. Same thing with rooms. I can take a look individually at that room, and a piece we're going to talk about with a discharge perspective is the ability to take a look at what room, what case manager, what social worker, what pharmacist if that patient is being discharged. So that's very helpful. Okay, so then we knew that we want to integrate this in some fashion, but we also were very cognizant of alarm fatigue. And so alarm fatigue is really those pieces of the technology we have anymore in healthcare is so voluminous that you can alarm on anything, but what is it that those things that you're going to really do something about? So we have an Avera-wide alarm committee, and the Joint Commission really did spur this conversation with their 2014 alarm initiative, but we needed to find out how can we get the most important information to those caregivers so that they are acting on actionable alerts and alarms. So we looked at the 4 of the top 10 safety concerns, and this starting in 15 all the way to 17. It's very interesting because the top 4, and you can see them on the screen right now, all are handled by virtue of how we utilize our smartphone system from both communication as well as result reporting and follow-up. And so just an interesting sidebar to the ECRI top 10, 4 of them are really handled in the technology that we've implemented. Also, we have what is our communication platform and how does that support the quadruple aim? Yeah, I'm sure you remember the triple aim where you had the first top 3, patient experience, pop health, and per capita cost were the top 3. We've added another one, and that is how do we improve the clinician experience? And so with that point in mind, I would like to turn it over to Michelle again.
Thank you. So we have a polling question for you to answer. Does your institution or health system struggle with managing patient discharges in a timely manner? Please select one of the following 2 answers and hit the submit button at the bottom of the polling window. So the answers would either be yes or no. And again, the question is, does your institution or health system struggle with managing patient discharges in a timely manner? You can answer either yes or no. We'll repeat the question one more time. Does your institution or health system struggle with managing patient discharges in a timely manner? Please select either yes or no. I have the results for you. And Candice, this is back to you.
All righty. So, and this is kind of an obvious one, although it is good to see. I know that there is a lot of initiatives on getting discharges out in a timely manner, but indicating that there's almost 70% that still have that issue. We have that issue, and even with this functionality, we still are working towards optimizing that as much as we can to be able to get a timely discharge. So real quick, I will just tell you what alarms and alerts come from our EMR, and then I will go towards the discharge piece of this. So I won't go over real specifics other than to tell you that we pull critical apps and direct to the nurse, so it goes to the person that's caring for the patient, be that a respiratory person or a pharmacist or an RN. We send all of our respiratory therapy orders and actually our physical therapy orders to the appropriate individual that's taking care of that. And then we also send our discharge orders to those individuals you see listed there. In addition to that, and really quick, I'll talk about the med administration. One of the things that we ran into when we didn't send those orders is the ability to get the order and act on it right away from a respiratory therapy perspective. So you can see the difference that we made between 2016 and 2017. Both of those years we had used the smartphone application. 2015, 100% of our caregivers said, yes, I've missed those orders. Now our, including the times that the patients refuse the therapy, we're at a 17% missed therapy. If we take that number back down, we're at about 10% that we've changed that number back down from much higher than that. So we are making inroads on that. Our benchmark on that would be great to have it between 3 and 5%. For those of you that are in respiratory therapy, you understand the dilemma with that. You're in one place, the order's in another place. You have half an hour to get there. So with discharge, we had the issue where we were getting the order, but we were just really having multiple handoffs with that. So what we really wanted to do is get that into the hands of the individuals right away. The minute the order is done in the EMR, it goes to those individuals that are taking care of that patient to get that discharge process to happen. This is an example of the order, and it shows you not only is it the order that's in there, but any specific comments that have to do with that, that comes from our middleware solution. And just, I'll go briefly through these statistics, and they're a little confusing, and we still have work to do. So the very top line is the average order to discharge from what it was before we went with our smartphone solution to what it went down to. So fiscal year 16, we were fully engaged in our facility, our largest facility, and we went to order to discharge at 3 hours, and we shaved off 22 minutes. We've stayed the gains, and we've lost 1 hour now, but I think we're looking at more initiatives. How can we get this down to 2 hours? From order to discharge, the benchmark really for us is 2 hours. We're working towards that, but you can see we did shave off 22 minutes just by virtue of getting the smartphone deployed. The next two lines are really time of day, and so that is the order was entered in at 11:52. We dropped that by 24 minutes. Statistically, with the amount of discharges we had, we're still at that 11 hour for the order placed. We'd really like to see that much earlier. And then the discharge out of the computer, we're discharging at about 2 o'clock in the afternoon, 24 minutes after 2. But the key number here is that even with those, keeping those same statistically non-significant between 16 and 17, and with 1 minute less, we updated what's called a churn rate. For those of you that are in that part of the technology, we increased by 10% the amount of discharges we see. So we're actually seeing more patients and holding the gains with these particular numbers. We're also moving our texting away from voice calls. So we started out, and this is last year, so we had 2.3 million text messages. Our voice calls were about 434,000. And that doesn't count landlines. That really is just the calls from the smartphone. And then we had about 511,000 alarm notifications in addition to the EMR alarms. We also have monitor alarms and nurse call alarms as well. And then 7,000 images. And if you think about how much communication an image can have between providers or caregivers, that is also a great efficiency. So what's next for us? Well, we really are pushing towards a system-wide deployment. We are also updating our EMR at the same time, and so part of it is just resources and how we can get into every one of our facilities. We would like to put, and we have some ideas from our critical access providers and caregivers, how we can put their clinic unique alerts along with their critical access hospital alerts, because that really is almost one platform, if you will, clinic and critical access facility. So that's something that we're working on. And then Volt really is going to be integrated in any of our future building projects. What you see is our next $170 million building project that will be happening on the picture. And then the next piece for, from an alert perspective is to get our IV smart pumps alerting to the phone, because right, that's one alarm that goes to the patient and not to the phone right now. And then any use case scenarios that individuals come up with. So I would like to hand it over to Chris now from Zebra, who can talk more about the clinical mobility that we use with our Zebra devices. Chris?
Thank you, Candice. What a great story you shared, and so generous of you to share your learnings and insights from deploying smart solutions to improve patient care. As Candice mentioned, I'm with Zebra Technologies. I'm going to spend just about 2 minutes or so briefly sharing a little bit of information about the device that's been used at Avera Health. The Zebra device is actually designed specifically for healthcare. It looks and feels similar to a normal consumer smartphone, but it's actually healthcare purposed with many different features designed specifically for a work environment and specifically for a healthcare environment. Zebra's device is a market leader in its space. As this case study showed, it's highly interoperable both with EHR systems and with Internet of Things medical devices as well. And it does many different functions such as scanning, voice communication, texting, etc., and much, much more. So it does integrate a number of disparate tools together into a single tool. And the unique capabilities of the Zebra device do focus on healthcare safety, security, manageability, reliability, task accuracy, and especially affordability. So that's some brief information on the device that was used in this situation. And what I'd like to also highlight is that as we've witnessed deployments throughout the country, what we have seen is lots of learnings, lots of challenges, lots of great successes as well. And we've tried our best to document and capture those. And these are white papers that we have created that we certainly would be happy to make available to anyone on this webinar. So with that said, I'm going to now turn it over to Cheryl McKay, who's the Chief Nursing Officer for Volt, and she's going to share a little bit about the Volt solution as well.
Thank you so much, Chris, and thank you so much, Dr. Friestad, for sharing your outcomes and talking to us about the process changes that you've made with Volt. I think it's so important for all of us to be able to collaboratively share together and learn together moving forward. Like Chris said, my name is Cheryl, and I'm the Chief Nursing Officer at Volt. It's my privilege to be here with you today. For those of you who don't know us, we are a leading mobile communication and collaboration platform in healthcare today. Founded in 2008, we provide integrated smartphone solutions for over 275 customers and approximately 150,000 care providers. Our applications help you, the care team, collaborate to provide care across the continuum, as you've seen from Candice's presentation, to be able to do that to the right provider in the right place at the right time. Our solutions are easy to use, they're easy to manage, they integrate with other solutions for maximal benefit, and they give you tremendous insight into care. Some of the features that Candice spoke about, the dynamic directory allows you to reach the right person at the right time very easily. It's quick and simple self-selection and assignment allows you to reach people as their roles change, as their environments or units change. And group messaging allows you to communicate with the whole care team so they can all be part of the same conversation and do things more efficiently. Things such as power search, and you heard about favorites and the flexibility of the system itself, I think, which Dr. Friestad did a wonderful job portraying. We are also very proud of our rankings by class the last 3 years in a row. And we strive to provide a collaborative culture and really truly partner with our customers, as you heard from Candice. We wanted to help you deliver and make good on that quadruple aim objective and be able to maximize care evidenced by those demonstrable outcomes. We are so glad that you could be with us today and join us on this webinar. and appreciate the opportunity to be here with you. I think with that, we will hand it back over to our moderator, Michelle.
Great. Thank you so much to the three of you. And this brings us to the Q&A portion of our program. So we would now like to invite you to ask live questions of our speakers. To submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewable by other audience members. And Candice, I have a question for you in terms of how long did it take for you to implement this process? I know that you're still implementing it across your healthcare system, but in the system, in the hospitals where it's live right now, how long did that take, and what was the training, the staff training like?
So we piloted on one unit, and then as is our history, and this may be, I know that there's two different theories on this, but we are kind of a big bang approach or tear the Band-Aid off, depending on whichever way you look at that. So we decided to integrate the system in the rest of our facility in our main campus, and then we also have another campus that's 110 behavioral health, to do that at once, because really you're communicating with each other a great deal. So we implemented in October of 2015 and saw that hospital through, and then we really wanted to make sure we had that footprint solid. The training was very helpful from our Volt staff to we do have educators in our facility. The training was very easy. Part of it is because everybody knows already to use the cell phone, and the system is very intuitive that way. And so I would say that the training was less than a half an hour, sometimes 15 minutes for every individual. And then sometimes our providers, we spend about 10 minutes getting them up to speed. But again, because you already know what that functionality is, it's very intuitive and very easy to train on. Then we did our other facility, or it's about a 70-bed facility that's in Yankton, South Dakota. We implemented that in February of this past year, and then we implemented our critical access facility in July. So we're really trying to ramp these up, have a best practice scenario for those different three entities, and then really, like I said on the slide, try to get it implemented by 2020 for the rest of our platform.
Great, thank you. We have a question. How did you convince providers to carry another device, a device separate from their personal device? Did this impact their ability to communicate in emergent situations, say if they're at dinner or if they're off shift?
So how we actually are a BYOD scenario, and so that we have that app on their existing device. And how we convince that is, if you are already texting on your personal device, that is a HIPAA violation, and we have, again, strong, great C-suite support in that, because they have clearly articulated what the fines would be in the event that you're using your personal device for this. So therefore, you really do have to use this secure system to be able to text patient-based and patient-related information. So that really was the impetus, and then if for whatever reason there is a accountability issue with that, we really go to our vice president level, senior vice president level for that, and we have also our medical information officers and our medical officers very supportive in that.
Great. Do the texts automatically get documented in the EHR?
We don't do that yet. We have talked about it and have indicated the functionality is certainly there to do that, but we have not gone there yet. A part of it was a conversation with caregivers going, you know, I want this information as much would be a conversation, that I wouldn't necessarily put all my conversations, be the verbal or in person, right, into the EMR. And so that was right. Currently we've kept that outside the EMR and let that documentation be separate. Okay.
We have another question. Did you feel any resistance from your older staff members who might be unfamiliar with the technology? And on the flip side, have you seen any issues with your younger or millennial staff with this technology?
Well, that could cover another webinar. So with, our platform right now probably covers about 5,000 users right now. And so absolutely, there were the issues with, and I'll take the older since I consider myself in that realm, seasoned, whatever. We had several nurses that were very concerned. They did not have a smartphone, and so how are they going to operationalize with this? We gave them training, and I think what happened immediately, I saw this happen 10 or 20 times, is that individual went out and bought a smartphone. Those that were using the Zebra phones that Chris was talking about, they would go get their own smartphone for home use because they probably did not realize until that point how efficient it was. And so that was a wide open light bulbs on in numerous units when that happened. From a millennial perspective, I think it's the flip side of that, of part of the reason why we ended up with the top 10 list is because they're used to the SUP or IDK or the use of emojis or a variety of different things that's just commonplace for them, and really getting back to this is a tool for you to use and it's efficient, but you still have to be professional with it. So I think that was kind of a dichotomy, and like I said, I could go on with different examples, but it certainly is a journey for both ends of the age spectrum.
Sure. So what has been the biggest benefit that came from adopting the communication platform that was not initially anticipated?
One example, I gave the one example with the provider. I'll give you an example of PAR. So post-anesthesia or PACU, we had just an anecdotal where the nurse had given report to the nurse in PACU had given the report to the nurse that on the floor, and during the course of her caring for her other patients, realized she still had the dentures from the patient she had already transported about 25 minutes ago. She knew the name of the nurse. She quickly searched her, and they had a quick text message about, hey, I'll drop this off at lunch, and the nurse texted back, yep, great, I was looking for those. I mean, it was, when the PACU nurse talked to me later, she goes, that one little piece saved her, she said, I bet an hour's worth of time between handoff, get this person, or she said, that would be the best case scenario, half an hour to an hour. Worst case scenario, the dentures don't get right back to the right patient. And that, as people on the call know, probably can be thousands of dollars for every year that may happen from an institution, depending on what your liability policy is. So that was kind of a really quick anecdotal while I have a one-on-one communication with the person I need to talk to.
That's great. Hey, Chris, this question is, we're going to switch gears, and this question is going to be for Chris. As a smartphone user, the listener's biggest concern is always its durability. How durable are the Zebra phones? I'm thinking in terms of screens breaking, fluids, et cetera. How do they stand up to the healthcare environment?
Sure. So the healthcare environment is tough on devices, as I think most of the audience realize. What Zebra has done is try to design a device specifically for the healthcare environment. So as an example, the glass is extra strength Gorilla Glass on the device. It's able to be dropped on hard surfaces and still hold up. There are seal protectants that are put onto the device that prevent liquids from touching the electronics, or importantly, healthcare disinfectants from reaching the electronics. There's also the seal protection also is very helpful for dust, which can get into devices and cause lots of problems in the performance of a smartphone device. So the Zebra device lasts typically 3 years plus. We have support services for up to 6 years. So it really is designed differently than the typical consumer phone. It's designed for the very rugged, demanding environment, which is, I think, helpful in deployment for that.
Great, thank you so much. Switching back to Candice, we've talked about the benefits of this platform, and one of our listeners has asked if you've experienced any resistance in implementing the software within the healthcare system.
So I'll give an example of our infectious disease physicians for this. So our infectious disease, we have several of clinics of those, but one of them is an independent provider, and so they cover not only our institution but a couple of competing institutions in the area. And they saw the individuals using this phone, and in my conversation with Dr. Nazir, he said, you know, I don't know that that's for us. And another physician who's maybe a little more tech savvy in that group came up to me, Dr. Kessler, and said, you know what, can I just try it? I said, sure. So we set them up. We looked at the best means of communication from infection control. It really is on everybody's mind, and these individuals are fabulous from a resource perspective from our facility. And so Dr. Kessler was on it for, I believe, a week and a half before I got a phone call that said, yeah, we all need to be on this. Can you come over next week? And so it really, the proof is in the pudding for a lot of this is once, for every provider I know, for every caregiver I know, it's all about time. And if I can save time or if I can have a richer communication, that is where is going to be the hugest benefit for any person that's in the healthcare arena. So I think that that's typically how we've done it, and then it's word of mouth from that point forward. It's, well, wait a minute, you should probably try this. So that seemed to be one of our best way of getting provider adoption, and especially when it's one of their own clinic colleagues or one of their own individuals in that same area.
Great, thank you. It looks like we have time for one more question, and the question is, what would be your best piece of advice to drive provider adoption?
Kind of what I just talked about before. Most of your providers that will be having difficulty with it may be those that hadn't used a smartphone. We're really getting to the point anymore where it's almost impossible to live or communicate without one. So consequently, as that goes, it really is what's the saving of the time? How much time can I save? And if this makes a difference from not only time efficiency, because time really is money, and patient safety and patient quality, then sign me up. I'm on board.
Thank you very much. Unfortunately, we have run out of time for questions. In closing, we want you to know that your feedback is very important to us. As seen on screen at the bottom of the current slide is a link to the evaluation. A live clickable link can be found in the resource list, as well as in the program evaluation widget at the bottom of your screen. And it will also appear in the slide window at the conclusion of the program. We would greatly appreciate your thoughts on our program today. I'd like to thank our speakers again, as well as our sponsors, Volt and Zebra Technologies, for joining us today and sharing their knowledge on this topic. And to our listeners, thank you all for putting aside so much valuable time to watch our program. We hope you found it informative, and we look forward to seeing you with other helpful programs in the future. Ladies and gentlemen, this concludes our program. Thank you again for joining us, and have a wonderful day.